So it is my pleasure to now introduce Dr. Teresa Brady. Dr. Brady is a senior behavior scientist in the arthritis program at the Centers of Disease Control and Prevention and has helped shape the public health approach to arthritis since the program's origin in 1999. Dr. Brady has primary responsibility for providing technical assistance on self-management education and self-management support and has been instrumental in bringing the science to the community in terms of public health action. Dr. Brady, thank you. Dr. Brady will talk about the arthritis from the public health perspective.
Thank you, Julie. Good morning, everyone. I'm delighted to be here. My assignment is to try to set a very broad stage for the beginning of this meeting. Some of you are coming from a more clinical perspective, some of you are coming from a more public health perspective, and it's really nice to be at a meeting where both of those are represented, and that doesn't happen all that often. And so I'm going to try to answer three questions in my presentation. First, what is the public health approach? Why is arthritis a public health problem? And then what does public health have to offer? And much of this will be review for you. Those of you who have written grant applications, you'll already know some of these statistics. First, what the heck is a public health perspective, also known as the things I didn't learn in OT or psychology school? I was trained as a clinician. I had no idea what a public health perspective was. And some of you may have been in the same situation. Core public health values, some of them they share with clinicians, things like utilizing and expanding the science base and reducing health disparities. I think we're all united in that. I think one of the places where public health is a bit unique is that it recognizes that it really has to work through partnerships. It really can't do it alone. And finally, that it emphasizes prevention. And back when I was a clinician, when I thought prevention, I thought, well, we're going to stop bad things from happening, which is true, but that's primary prevention. I didn't really recognize secondary or tertiary prevention, and I'll come back to that a little bit later. But so all of those are important from a public health perspective. The public health approach is really designed to both measure and respond to health problems or risk factors, so we don't wait for the bad things to happen, and looking at population groups, so not necessarily individuals. And then trying to foster change at a system level so that we can affect change and affect large population groups. It's not really the treatment of an individual person, so that where the clinicians are really focused on that one person right in front of them, from a public health perspective, we want to be focused on the broad network of different people. Now, there are public health clinics that are individual clinical care clinics, but that's not really the broad public health approach. So public health's challenge is really to identify and then implement those strategies that improve the health of the population. Public health also works at multiple levels. And again, this is something when I was sitting in front of a patient, this is something I didn't think about, that it's not just that individual, but that you can work at the community level, at the organizational level, at the public policy level. And it's actually important to do that, which is not when I'm wearing my clinician hat or was wearing my clinician hat, things that I thought about. And finally, this is the infamous, at CDC at least, the public health impact pyramid. And when you're working one-on-one with an individual, that's critically important. But to have a broader impact, you need to move down the public health impact pyramid. You need to be looking at those environmental changes or addressing social determinants of health. So clinical care and individual care is important, but that broad population care is important as well. Second question, what makes arthritis a public health problem? And it hasn't been recognized as a public health problem for very long. So this is why does public health even care about arthritis? And arthritis has been recognized as a public health problem only for about 15 years. And in 1999, sort of three pivotal things happened. The National Arthritis Action Plan was published, and it was from a public health perspective. The first ever congressional appropriation specific for arthritis was released. And finally, arthritis for the very first time showed up in Healthy People 2010, which is the nation's health agenda. So those three events together sort of propelled arthritis onto the stage as a public health problem. So there were really 4 reasons in 1999 that public health began to recognize that arthritis was a problem. Because it was a large and growing problem, that it seriously impacted people's lives, was costly, and there was a niche. We could do something about it. So I'm going to take those one at a time. First, hopefully everyone in the room recognizes the definition of arthritis, the sort of broad umbrella of over 100 conditions that affect the tissues and joints and surrounding tissues. There are, in that 100 types of arthritis, there are some that are obviously far more common than others. The big gorilla in the zoo here is osteoarthritis, which affects 27 million American adults, where fibromyalgia affects 5 million, gout 3 million, rheumatoid arthritis 1.5, and in decreasing on down. So that even though we're talking about large numbers of people, that's not evenly distributed among the various types of arthritis. This is sort of what we lovingly call the arthritis snapshot. The current data says that 52.5 million American adults have some form of arthritis, a self-report doctor-diagnosed arthritis, and I'm going to come back to that in a minute. Arthritis makes up 5% of all ambulatory care visits. Almost 23 million Americans report some kind of activity limitation due to their arthritis. There's 750,000 hospitalizations due to arthritis. And the reason arthritis wasn't previously recognized as a public health problem is we're just not a killer. There's only about 10,000 people who are recognized as dying from some form of arthritis. And in the past, public health has really focused on those killers. And only in the last 15 years or so have they begun to look at conditions that actually may kill quality of life, but don't actually kill the individual. And when we look at a public health definition of arthritis, and when we first began planning the National Arthritis Action Plan, this is one of the stark differences between the clinicians and the public health people in the room, because clinicians, of course, need a diagnosis. They need to know exactly what it is they're treating. From a public health perspective, you never have the luxury of a specific clinically derived diagnosis. So all of our surveillance statistics are really based on this self-report doctor-diagnosed question. So have you ever been told by a doctor or other health professional that you have some form of, and then we list a number of forms. And this actually has quite good reliability. So we're fairly confident that in casting a broad net of people with arthritis, this question does get at that. When it comes to the specific form of arthritis, people are not very reliable in reporting that. But they are reliable in saying, yes, I do have, a doctor or other health professional did tell me I have some form of arthritis. So all of the statistics that I'll be showing you from here on in are based on this public health definition of arthritis. So I said before that the current statistics just released last November is that 52.5 million US adults have arthritis. So that's more than 1 in every 5 adults. So obviously it's a big problem. That's approximately 50% of the people over age 65 have arthritis, and that's that stereotype that arthritis is just for old people. What some people are surprised at is that more than 2/3 of the people with arthritis are actually under age 65. So while it's very prevalent among the elderly, it's not necessarily an elderly disease. It's more common in women than men, and it's more common in whites and blacks than it is in Hispanics or Asians. The tricky part about this, though, is that while the prevalence is lower in some of those minority groups, the impact, the disability, and the pain and things like that are actually more severe in some of the minority groups. So sort of a broad snapshot of who has arthritis. It's a large problem, it's a growing problem, and this is actually estimates that are looking purely at the aging of the population, predicting that the number of people with arthritis will grow to 67 million by the year 2030. Now these numbers may end up being off because this does not take into account the obesity epidemic. This is purely based on the aging of the population. So arthritis is a large problem and it's a growing problem, which is part of why public health is interested. It's also a problem that's seriously affects people's lives. This is the graph of the most common causes of disability, and since we've been doing these calculations, arthritis and rheumatism has always been at the top of that list. So employers are often surprised to see that it's not back pain, it's not mental health, it's actually arthritis that's that leading cause of disability, most common cause of disability. In addition to projecting the prevalence of arthritis increasing, we're projecting that the prevalence of arthritis-associated activity limitations will also increase up to, at the time that these projections were done, we were predicting an increase of up to 25 million U.S. adults with activity limitations due to their arthritis by the year 2030. So when we look more specifically at activity limitations, 43% of the people with arthritis say that arthritis in some way affects the activities that they do every day. And that equates to 10% of the U.S. population. So 10% of the U.S. population, 10% of the people in this room would report that arthritis limits their activities in some way. On a parallel is work limitations, and approximately 1/3 of the people with arthritis report that arthritis affects their ability to either work, how much they work, whether they work at all, things like that. And that translates into 5% of the population. So it has a significant impact on work as well. It has a significant impact on social participation. 10% or 11% of people with arthritis report that the arthritis impacts their ability to fulfill their social roles. And volunteerism. Among people who volunteer, almost half of them say that their volunteerism is restricted in some way due to their arthritis. And some of these statistics came from the work of my colleague Christina Tice, who's over in the middle of the room there. So arthritis, not only is it a large and growing problem, it seriously affects what people need or want to do on a day-to-day basis. A few other select impacts. 26% people report that they had severe pain in the last week. Almost 1/3 of them report some anxiety from their arthritis. Almost 20% report depression related to their arthritis. And then 2 to 4 times as many unhealthy days, which is a sort of public health way to look at quality of life. So compared to people without arthritis, they have at least twice as many, sometimes 4 times as many unhappy days due to either physical or psychological issues related to their arthritis. So arthritis has a significant impact on people's lives. The third reason that public health was initially interested is that it's costly both to people and their families and to society. And some of those are those broad quality of life impacts, but some of them are pure dollars and cents. And these are relatively old statistics. They're based on a 2003 estimate, and at that time we estimated that arthritis cost the U.S. economy $128 billion. Almost 2/3 of that is in direct medical costs. The remainder is in lost productivity. We expect new numbers to be coming out in the next probably 4 months, and they will be significantly higher than this. At the time, this 128 billion was the equivalent of a modest recession. So the cost of arthritis was equivalent to a modest recession, and that's probably going to increase when we have new numbers. So it has big impacts on an individual level, but it has big impacts on a societal level as well. And then finally, the reason that public health got interested in arthritis is there was something that public health could add to what was happening clinically. And there again, we're looking at the prevention opportunities. When we're talking about primary prevention, preventing the bad thing from happening, preventing disease onset, we don't have that many modifiable risk factors identified yet. Obviously, if we could eliminate obesity, we'd eliminate a lot of osteoarthritis. We're not very good at that yet. If we could eliminate injury, we sort of jokingly in the office say, well, if we could just outlaw football, we'd be really ahead in knee osteoarthritis. That's probably not going to happen as well. So we have some opportunities in primary prevention, but that's probably not where our biggest bang for the buck is right now. We have some opportunities in secondary prevention. Secondary prevention is trying to identify things early through screening and early detection. And probably our biggest opportunity there is really in the area of inflammatory arthritis. And if we can get those people into the effective medications quickly, that would sort of be a secondary prevention opportunity. The biggest opportunities right now seem to be in tertiary prevention, so trying to prevent the complications that occur from the condition. Those are the strategies that currently have the strongest science base and the best opportunity to reach those 52 million people already have arthritis. So the opportunities there, the things that we know make a difference, are really trying to reinforce or develop self-management behavior. So whether that's helping people be more physically active, whether that's helping people lose weight, attending self-management education programs. So most of our current efforts at CDC are around these broad self-management, either self-management education or physical activity programs, getting those programs into the hands of the people who need them. We could also be doing a little bit of work in early diagnosis. So that's really where we see the critical public health opportunities at present, while we're still trying to identify modifiable risk factors that we could intervene on to try to prevent arthritis from happening at all. So those were the 4 reasons that the public health community first got interested in arthritis, and all of them are still true. However, over the last 15 years, a few more reasons have emerged. In the first place, the rate of activity limitation is actually progressing faster than projected. We now recognize that arthritis is associated with a couple of general health risk factors that are of critical importance, both the obesity epidemic and physical inactivity. And finally, we recognize that arthritis co-occurs with some other chronic conditions that are of high priority as well. So I'll go over each of those very briefly. First, the rate of activity limitation is progressing faster than we expected. And this is fairly new data from last fall. I showed you this slide a minute ago about the projections for the increase of both arthritis prevalence and activity limitations. The data that came out last fall said that we're already past the 2015 projection. So this is data for 2010 to 2012, and we've already exceeded where we expected to be in 2015. So, one data point doesn't make a trend, but the picture doesn't look good in terms of activity limitation. So clearly we need to be doing more to intervene in arthritis. The second reason that's emerged more recently is that arthritis is associated in some way, and we can't necessarily know how, with both the obesity epidemic and physical activity. And on this slide, you can see that more adults with arthritis are obese. So in yellow, we have the doctor-diagnosed arthritis from that public health perspective. Green are the people without arthritis. And obviously, the more people with arthritis are obese. More people with arthritis are also physically inactive. About a little bit over 1/3 of the population in general are inactive, but among people with arthritis, it's 43% who are sedentary, who are not getting any physical activity. So we know that arthritis can interfere or shackle our efforts to address obesity, and you know how big the obesity efforts are currently, even Mrs. Obama's interest in obesity, and physical inactivity, because we know that people with arthritis are more often obese, more often inactive. The flip side is also true. We know that people who are obese more often have arthritis, and we know that people who are physically inactive more often have arthritis. Now, it's kind of a chicken and egg thing. We don't know what comes first, but we know they go together. So we're never going to really be able to address obesity or physical inactivity unless we also address arthritis. And so the combination, if you have arthritis alone, 16% of those people were physically inactive. If you had obesity alone, 14% were physically inactive. The combination of obesity and arthritis, 23% of those people were physically inactive. So the combination keeps people more sedentary. And that's a problem because there are some arthritis-specific barriers to physical activity. And this came from research we funded specifically with people with arthritis. And what we learned is that people with arthritis have the same barriers that the rest of us do to physical activity. And some of these, those of you who have tried to be physically active, have used these same excuses, I think. I don't have time, I'm too tired, I don't really like to exercise, I don't have anybody to exercise with, I just don't enjoy it. Sound familiar? Any of you used any of these? Never. But what we learned is that there's also arthritis-specific barriers. So they not only have the barriers that an ordinary person has, they also have additional barriers. A key one there is pain. Pain before exercise, during exercise, after exercise. It's natural. If something you think is going to cause pain, you don't really want to do it. They perceive that exercise is going to do bad things to them. I'm going to get worse if I exercise. They are uncertain about what's considered a safe type of exercise, and they don't know where to get a safe exercise program. They don't know what types of activities to pursue. Their doctor didn't tell them to exercise. And finally, the weather. And we all have weather conditions, but for people with arthritis, it's not just it's inconvenient and I'm going to get wet, but changing weather conditions makes me feel worse. So to really get people moving, we not only have to address those common barriers to physical activity, we have to address the arthritis-specific barriers. And even if someone's really focused on obesity or really focused on another chronic condition, if you're not addressing the arthritis-specific barriers, you're probably not going to be able to succeed in increasing the physical activity. So the first two additional reasons are that the rate of of activity limitation is progressing, and that arthritis is associated with both obesity and inactivity. And in addition, it co-occurs with and complicates the management of other chronic conditions. So almost half the people with diabetes and half the people with heart disease also have arthritis. So even if you don't care about arthritis, even if somebody cares about heart disease or diabetes, and there's lots of effort and money going into heart disease and diabetes right now, if they don't address the arthritis among their people, they're really not going to succeed in managing either the diabetes or the heart disease. And again, similar to the obesity story, if you combine diabetes with arthritis, or with heart disease, you end up with greater arthritis attributable activity limitations, and you also end up with greater inactivity. So the combination of arthritis with another chronic disease, it can be deadly in terms of that inactivity. And as you know, if you're interested in heart disease or interested in diabetes, a critical strategy there is physical activity. And you can do all the preaching you want around people with heart disease should be physically active, but if their joints are telling them no, they're not going to get out of the chair. So we really have to address the arthritis, even if what we're interested in is addressing diabetes or heart disease. So that's really kind of a silver lining for us here. We know that people are managing multiple chronic conditions, and from our audience research, we know that arthritis is often not top of their list. If they have heart disease or diabetes, they're generally more worried about their heart disease and diabetes than they are their arthritis, because they just think everybody gets arthritis. But we do also know that those arthritis-specific barriers are going to cause some limitations. So the silver lining here is that the same self-management behaviors, physical activity, self-management, education, can help their diabetes and heart disease as well as their arthritis. So we don't need distinct programs for every condition you have. If we can turn people into active self-managers, and we don't care why they do it, if they're interested in learning to do it because of their diabetes, it's going to help their arthritis as well. So we don't have to be disease-specific here. All right, so we've talked about why arthritis is a public health problem. What does public health have to offer here? And there's a couple things that I think are important in terms of why we care if public health is interested in arthritis. And the first, and this math I did actually just for healthcare providers, we have to recognize that most arthritis care does not happen in the clinical setting. And if you assume a person sees their doctor 3 times a year and for 30 minutes, and how many of you have had a 30-minute doctor visit? Like nobody. That still turns out to be less than 0.02% of their time each year. So if they don't learn how to manage their arthritis themselves using the clinicians, whether it's physicians or PTs or whoever as consultants, they're never going to succeed. So we need some public health services to help them learn how to manage. In terms of contributions from public health are the people who do all that surveillance, come up with all the numbers that you put into the introduction section of any of your grant applications. Public health funds a small amount of prevention research, although I was a little green with envy when Teresa was talking about all the programs and the money that they have to invest in research. We obviously don't have that much money to invest in research. But public health is able to put arthritis on the agenda, the national health agenda. It's able to address arthritis through multiple levels and with multiple partners. And the real focus is on research translation. So currently, I told you that 2010 was the first time that arthritis was in the nation's health objectives at all. It continues to be in the health objectives of 2020, and you can see that there are the key symptoms that we're trying to decrease and key interventions that we're trying to increase. So arthritis is now part of the national agenda for improving the nation's health. When we're thinking about addressing arthritis from multiple levels, this is actually a document put out by the Arthritis Foundation that's really trying to address or identify what some of those environmental or system changes would be that could help make people more physically active. And I think there's going to be a presentation later today that's going to review some of that same information. Public health community, including the Arthritis Foundation, worked together to develop a public health agenda for osteoarthritis a couple years ago. And from that, the Arthritis Foundation created the Osteoarthritis Action Alliance, which was a coalition of a variety of different stakeholder groups with that mission to work collectively to advance the recommendations in the agenda, have a number of action teams. So again, that's moving beyond that clinical perspective, trying to push toward other levels of influence to address arthritis. And finally, I told you earlier about the public health challenge to identify and implement strategies for improving the health of entire populations. And so that's really where we're trying to translate research into public health action. And that's the public health challenge, but the challenge I'd like to issue to you today is it's all of your challenge as well. It's not enough to do great science, and we're going to hear some of the state of the science today. What's critically important is to figure out how to get that science out to the people who can implement it to improve health. So one of the ways that CDC is doing that is by funding state arthritis programs to disseminate some of the evidence-based self-management interventions. We're also funding a few national delivery system partners to try to do the same thing, to try to get interventions to the people who need them. The strategic approach is the same, and that's really trying to embed the interventions into existing delivery systems. We can't create a delivery system for every new intervention we have, but we have to take the interventions we have, and if you have a clinical intervention, if you have an intervention that you want to change practice for PTs, you got to figure out how you're going to get that intervention to the people, the PTs who could use it. And I think we know from all the clinical guidelines literature that just having a good idea and putting it in the literature, that doesn't change anybody's health. We got to figure out how we're going to make that true public health broad-based action. So my challenge for you today is from the beginning in our discussions today, and when you go home and start thinking about whatever projects you're going to do, plan for translation from the beginning. Think about where could the target audience most easily get this intervention, who is well positioned to provide the intervention, and finally, what organizations could make this intervention part of their routine work and critically could get supported, whether that's reimbursement or some other kind of financing, but could get supported for doing this kind of work. So today we're going to be talking about state of the science, the important things that are happening, but again, we really have to spend more time and energy from the beginning thinking about how do we get that work out to the people who can implement it. So that's public health's challenge, but it's also my challenge to all of us today. So in summary, arthritis is a public health challenge or a public health problem. It's a large and growing problem. It's costly to people, to society. It shackles our national efforts to address either obesity or physical activity, and it sabotages any efforts to address diabetes or heart disease. So it's a critically important health issue, even though it's not considered a killer disease. We need to work through those multiple venues and multiple levels of influence. We need to go, clinical work is important, but we need to go beyond that into the community and to the policy level as well. And finally, we need to address those challenges to translation to make sure the good work we're doing gets out to the people who need them. All right. Okay, I get one or two questions.
Thank you very much. That was a great overview. One of the comments you made that I agree with generally, but I have a little bit of concern with some of the evidence that's coming around arthritis. And there's that comment about sort of the self-management programs and particularly the exercise components, that we don't need disease-specific programs. And so I think one of the things for arthritis that we're starting to recognize, and there's some very good programs in Scandinavia that have started, where I think all of us agree that the aerobic and just being active gives you a certain effect that is very beneficial for the cardiac and the diabetes piece. But there's growing evidence that probably some targeted joint-specific components are actually really important and starting to show to have even bigger effects. And so in thinking about that in the relation of the translation component, how much evidence and when is the right time to try and do that public health messaging to start to get that perception of just a general self-management program is sufficient?
I think that's a good comment, and I want to clarify. I think sometimes there is a role for disease-specific, absolutely, both from when there's some very specific thing that needs to be addressed, or from patient preference. When we've done audience research, some people actually want a program that's labeled arthritis safe, and some people want to go to a general program. I think when it comes to tailoring to an individual, then you're sort of crossing into the more clinical realm, not the public health realm. And absolutely, in the clinical realm, you need disease-specific interventions. So I think it's probably a series of building blocks, and probably the most critical building block is getting people started doing something, and then you can tailor that, and you may have to tailor it. They may be able to do some of their work, they may be able to do some of their conditioning in a general program. Some of them won't start a general program until they've already been through an arthritis-specific program. So I think it is a blend of both. But definitely, I wouldn't abandon either one, but recognize when we're trying to get people off the couch, if it's their diabetes that motivates them to get off the couch, more power to them. Yes?
Teresa, very nice presentation, Dan White, Boston University. I just was wondering about the chicken and egg comment you made about physical activity. And some of the literature that I've done and some of my colleagues have done actually have not found a difference in the amount of physical activity people have done when you objectively monitor it between those who have arthritis and those who don't, and among those people who have pain and those who don't. So I wonder if it's less the arthritis that's causing the physical inactivity, and it's more just the state of our how we are as people, and arthritis is more of a secondary component of that.
And I think that's where we need a lot of research. I know your group is doing some research in that area, and I think the picture will become more clear, and you're sort of getting some sort of hints of information there. And that's also why we need to address it from an environmental perspective, because I would agree that our society has built us into a sedentary society. And I think as we go on, there probably will be increasing evidence in terms of which, and it may be different for different people as well.